Hey everyone, today we're going to be talking about chapter 15 and we're going to be discussing a very in-depth topic called schizophrenia. And this chapter is kind of long, so I'm going to try to make this PowerPoint as short as possible for you. When someone's dealing with schizophrenia, they experience all types of behavioral situations. They hear voices, they have hallucinations, they have delusions, and these voices tell them to do harmful things. So we're going to learn the different forms of schizophrenia, and there's a lot of terms in this chapter, so you really need to focus on the terms. Some of that will be on the test. The objectives are listed here on your screen, and you can read these for yourself. But we are going to definitely look at the different concepts of schizophrenia and what your role is as a nurse when you're dealing with a patient with schizophrenia issues. So how is schizophrenia defined? In your book, and I'm on page 340, the term schizophrenia was defined in 1908 by a Swiss psychiatrist, Eugene Bleuler, and the word was derived from the Greek word schizo, meaning split. So it means that your mind is split from reality and to non-reality. Your thought processes are not realistic. Um, although there's two different ways to look at schizophrenia. Schizo again meaning split, and phren meaning mind. So your mind can be split. And again, what that means is you're just not thinking in reality. You have no concept of what being realistic is. For example, you may hear voices telling you to harm yourself, and realistically, we know we shouldn't harm ourselves, but a schizophrenic patient doesn't know that. They're very high risk for suicide. So, what are two general factors? The first factor is that schizophrenia is probably not a homogeneous disease. Um, it is a schizophrenia spectrum disorder, and it has several etiological influences, and that means causes such as genetics, biochemical dysfunction, physiological factors, and psychosocial factors. So they think these are some of the reasons that patients experience schizophrenia. The second factor that we need to consider is that clinicians have determined there never may be a single treatment or even a cure. Uh, there's really not a cure. It can be treated with certain medications, but there's no cure for this disease. People live with it once they're diagnosed, have it the rest of their life. Effective treatment requires a comprehensive, multidisciplinary effort, including pharmacological or medications, along with other things such as group therapy, family therapy, social skills training, rehabilitation, and these folks are in treatment for the rest of their life. Of all the mental illnesses that cause suffering in society, schizophrenia is likely responsible for longer hospitalizations, greater chaos in family life, more exorbitant cost. It is very expensive to get treatment, and that's why a lot of people suffer, because they can't afford treatment. And so studies have shown that people with severe mental illness like schizophrenia have a shorter lifespan than other people. Usually this is about 25 years or less. Effective treatment requires, again, a comprehensive approach, and you have all these different pieces they're looking at, like living skills, how to deal with the voices, how to tell the voices to stop talking to you. They do that in specific types of therapy. Risk for suicide is a major concern. About 20 to 40% of people with schizophrenia attempt suicide because the voices tell them to harm themselves. Schizophrenia is probably the most devastating illness in mental health. Uh, these people just become very detached from reality, and they, in severe cases, they hear these voices. And so these voices tell them again to do bad things. And sometimes these folks can never get these voices out of their head. The nature of the disorder, psychosis is a severe mental condition in which there is disorganization of the personality. So their personality changes. They have deterioration in social functioning. So most people with schizophrenia are not able to be sociable, hold down a job. When they're in crowds and they hear loud noises, they think these voices are talking to them, and they get very confused in large groups because of all the noises, and they think it's just a multitude of voices talking to them, so they do not do well in groups, so they usually can't hold jobs. um, they have deterioration in social functioning and a loss of contact with or distortion of reality. Again, they are out of touch with reality. Their thinking is not realistic. Again, like I said, if I try to harm myself, I know I shouldn't do that because it can be detrimental, but they don't think that way. They see no remorse in their actions. There may be evidence of hallucinations, and these are false sensory perceptions not associated with real external stimuli, and delusions. These are false beliefs. So hallucinations are a lot of times things that they can see and hear, and delusions are thought processes that are not realistic. Psychosis can occur with or without the presence of organic impairment. So, in other words, they can go into a psychotic episode over anything. Anything can trigger it. A fever, change in their medication, change in their daily routine. The voice is becoming louder in their head. And some of these medications help control these voices. The characteristics, you see disturbances in thought processes, so they're incoherent with their cognition is impaired. They have disturbances in perception, and affect invariably result in severe deterioration of social and occupational functioning. They cannot function in a large crowd. Most of these folks stay indoors. They don't get around people. They're very scared. They're very afraid. Uh, Everything terrifies them. They don't eat, they don't bathe, they can be afraid of their food, they have difficulty watching TV because of the voices on the TV. Symptoms generally appear in late adolescence, early adulthood, although they may occur in mid or late adulthood. Early onset schizophrenia refers to symptoms that begin in childhood and adolescence before age 18. This condition, although it is rare, is recognized as a progressive neurodevelopmental disorder with a chronic and severely symptomatic course. And so, you may see symptoms in childhood and just not know, you just may think it's an odd child or just being a child. And in reality, as they become an adult, the symptoms manifest and they are diagnosed with schizophrenia. On page 341, you have four phases: the premorbid phase, prodromal phase, active psychotic phase, and the residual phase. In the premorbid phase, signs are those that occur before there is clear evidence of illness and may include distinctive personality traits or behavior. Premorbid personality and behavior measurements that have been noted include being very shy, withdrawn, poor peer relationships, they do poorly in school, and they demonstrate antisocial behavior. They're very quiet, passive, introverted as children. They have few friends. As adolescents, they have no close friends, and they avoid any kind of like social activities such as at sports. They really cannot tolerate being in a crowd. Phase two is the prodromal phase, and the signs are differentiated from premorbid in that the signs are more clearly manifested as the illness begins to develop. You start to see frank psychotic symptoms, and frank means they're there. You can actually see them. It may be brief or a few weeks, but it can be about 2 to 5 years. The individual begins to show signs of significant deterioration. Social withdrawal is not uncommon. Their cognitive impairment begins to emerge, and you really notice that the things they say don't make any sense. They also become very OCD, obsessive compulsive, and you will see them hoard things, put on multiple layers of clothes, pile up newspapers. They're very careful about how they eat their food. A lot of times they won't even eat. They're very skittish in this phase. And then phase 3, you are in active psychotic phase. And this is where you are having psychotic symptoms. And you'll see these in box 15-1 on page 342. You have delusions, hallucinations, disorganized speech, frequent derailment or incoherence. You have catatonic behavior. This is where catatonic means you may get in a position and stay there and not move for hours. There's positive and negative symptoms, and we're going to talk about those later in the chapter. And then phase 4 is the residual phase. And this is where you have periods of remission and exacerbations. It usually follows an active phase, and then they kind of come out of it, and you will see sometimes no symptoms at all in this phase. But it doesn't mean they're cured. It means that they are just in a time of remission. Make sure you know those 4 phases. Predisposing factors. Studies show that individuals with schizophrenia have a higher probability of developing the disease than the general population. So if I were schizophrenic, my offspring would be very likely to have schizophrenia. The dopamine hypothesis, this is where you have an excess of dopamine. This excess may be related to an increased production or release of the dopamine. And so medications are made to help reduce this excess production of dopamine. Some of the medications that you have to stay away from are such as amphetamines, which increase levels of dopamine, induce symptoms that mimic those of psychosis. Antipsychotics such as chlorpromazine and haloperidol lower brain levels of dopamine. So you may see, you don't want to give them amphetamines, but chlorpromazine and haloperidol are some of the drugs of choice. These help by reducing the symptoms, by reducing the excess production of dopamine. Then you have the biochemical hypothesis. You have abnormalities in your neurotransmitters, such as norepinephrine, serotonin, acetylcholine, and your gamma-aminobutyric acid. And so there's medications that help repair these abnormalities in your neurotransmitters. Psychopharmacological studies have shown that the drug class of glutamate antagonists, such as phenylcyclidine, ketamine, can produce schizophrenic-like symptoms in individuals without the disorder. So there are some medications out there that can cause schizophrenic-type behaviors. And then other issues, abnormalities in neuroregulators such as prostaglandins and endorphins. Some other physiological factors are viral infections at birth. So some type of virus was contracted during the birthing process and caused, some damage to the brain function. You may also have anatomical abnormalities in the brain. You may have changes in the hippocampus of the brain. And then physical conditions such as epilepsy, Huntington disease, birth trauma, head injury, alcohol abuse, cerebral tumors, CVAs, uh, your SLE, this is systemic lupus, Parkinson's, Wilson's disease. All of these affect brain function. And so we know that schizophrenia is a disorder that is affects the mind. Remember, it's that splitting of the mind. Then your book talked about some environmental influences, such as becoming from lower socioeconomic backgrounds, which causes poor family relationships, which leads to poor parent-child relationships, and dysfunctional families. People who suffer financially often have very dysfunctional families. So schizophrenia, one of the theories is that it can be learned behavior from the way a person's being treated. Living in poverty, inadequate nutrition, absence of prenatal care, any stressful life event. On page 346, you have box 15-2, and it lists general medical conditions that may cause psychotic symptoms as well. And so these things would have to be ruled out. And so when you're doing your health assessment, you need to look at the demographics. What are their medical conditions, or what are their living conditions? Is there any abuse? Did this child not get proper care? People that live in poverty don't go to the doctor, so symptoms go unnoticed for a long time, and by the time it manifests itself, sometimes it's too late. Even to use medications, the patient needs to be institutionalized for safety. On page 348, before we get to that, I do want to look on page 347 and talk to you about the word catatonia. This is a significant motor disturbance that may range from stupor, no motor activity, to excessive motor agitation and activity, or excessive movements. And you may see catatonic behavior during schizophrenic episodes. Make sure you look at that, okay? And then on page 348, it talks about brief psychotic disorders, substance and medication-induced psychotic disorders, and psychotic disorders because of medical conditions. So there are other things that can cause psychotic behavior and psychosis that's not schizophrenia. So these things have to be ruled out. Make sure that you read these paragraphs on page 348. Because some people do have psychosis. Think about the alcoholic. They see hallucinations when they're in a stupor state of drunkenness. People who take drugs, they have a high and it alters their mind processes, and they see things and they have hallucinations. It doesn't mean that they have schizophrenia. Again, your book talks about substance and medication-induced psychosis. This is listed for you on page 348, box 15-3, and it lists the drugs and medications and certain toxins that can cause psychotic disorders. A fever. Somebody can have a UTI, and it can cause them to have psychotic episode, but it doesn't mean you have schizophrenia. And again, on page 346, general medical conditions as well. Okay, so on page 349, it gets into talking about the different types of schizophrenia. So you have schizophrenia form and schizoaffective disorder. Schizophrenia form is identical to those of schizophrenia, except the time frame is at least 1 month, but less than 6 months. If it persists longer than 6 months, then it's changed to schizophrenia. Okay, so say the person had an episode and they didn't have an episode again for 2 years, then it would more than likely be schizophrenia-form disorder. Schizoaffective disorder, you see symptoms associated with mood disorders such as depression or mania, and a lot of people who have bipolar have schizophrenia as well. They may appear very depressed, they have ideations of suicide, or they may feel euphoric, like nothing's going to happen to them. They may have grandiose behavior, which means and I talked about that in bipolar, um, they're somebody great and grand, and they're very hyper. They have a presence of hallucinations or delusions for at least 2 weeks in the absence of a major mood episode. So if there's not another mood disorder going on like bipolar, then we can diagnose this as true schizophrenia. The application of the nursing process, this starts on page 349, and you may have to get information from the family because the patient may be so disconnected from reality that they can't answer your questions. And here we're going to look at the positive and negative symptoms of schizophrenia, and you need to review these. Several of these will be on your test. Box 15-4 on page 350 lists your positive and negative symptoms, but your book does a great job giving you examples of these. So let's look at delusions of persecution. These are the most common types in which individuals believe they're being persecuted or malevolently treated in some way, or malevolent. They think somebody's plotting against them. In other words, they think people are out to get them. They think their home is bugged. They're very paranoid. They have paranoid delusions. They're very suspicious. I won't eat this food because I know it's been poisoned. They have grandiose delusions. The individual has an exaggerated feeling of importance and power of themselves. They believe they're Jesus Christ. Delusions of reference. Events within the environment are referred to by the psychotic person as himself or herself. Someone is trying to get a message to me through articles in a magazine or the TV. I must break the code. They believe that messages are being sent to them. Delusions of control. The individual believes that certain objects or persons have control over their body, like the dentist put some kind of transmitter in their mouth. They have magical thinking. The sky is raining because I'm sad. They made that happen. Somatic. We know that somatic means a false dysfunction of a body part. The doctor says I'm not pregnant, but I know I am. There's an alien eating my brain. They're very bizarre in the things that they say. They have nihilistic delusions. The world no longer exists. I have no heart. It just doesn't make any sense what they're saying. Erotomanic delusions. They falsely believe that someone, usually in a high status, is in love with them, like the president or a famous rock star or something. Jealous delusions. It centers on the idea that the person's sexual partner is unfaithful. And a lot of times with jealous delusions, you see uh, situations where the schizophrenic patient will cause harm to their partner and often try to kill them. Disturbances in thought processes, such as in speech. Loose associations. We wanted to take the bus, but my lunch was cold. The FBI is watching. No one needs to pay to get to heaven. We have it all in our pockets. They're saying stuff, but it's loose. It doesn't mean anything. It doesn't connect. Neologisms. This is one of my favorite ones because they make up words. She wanted to give me a ride in her new uniform. They just make up bizarre words that absolutely make no sense. I like clang associations too. It's very cold. I am cold. I am bold. The gold has been sold. They use words that rhyme that sound the same. Word salad means absolutely nothing. It's like a salad. There's multiple things thrown in it. Most forward action grows life double place circle uniform. Nothing. Cucumbers, tomatoes, cheese, lettuce, word salad. Circumstantiality, the individual delays in reaching the point of a communication um, because of unnecessary and tedious details. The point or goal is usually met, but only within numerous interruptions to keep the person on track. You ever talk to someone, and when you get through talking with them, you don't know what they said, and they're trying to tell you a story and they have to go in this grave detail and they never get to the point of the story. That's what this is. Tangentiality refers to a veering away from the topic of discussion and difficulty maintaining focus and attention. So you're talking about a topic, but you can't stay focused on the topic. You veer off on another topic. Perseveration, the individual persistently repeats the same word or idea in response to different questions. They're kind of stuck on a particular thought. Echolalia, repeating words or phrases spoken by another. Toddlers do this. My little grandson does this a lot. But as an adult, we shouldn't do this. Um, So other positive symptoms, disturbances in perception. So here's where you have auditory, visual, tactile, gustatory, or olfactory hallucinations. So auditory is one of the big ones. Command hallucinations, the voices. They're telling these people to do bad things. And they actually hear these voices. They hear people talking to them. In training to restructure the thinking process, one of the things they do in therapy is to tell the person, when you hear the voices, tell the voices, stop talking to me, stop. And you'll see that in the care plan in the book. Visual hallucinations, they actually see things. They see false images. And the best thing to do is don't say, I don't see that spider. There's no spider over there, because you're going to agitate them. You need to say, I know you see a spider, but I don't see a spider. Tell me more about the spider. Then tactile, this is false perceptions of the sense of touch. They feel like something's crawling on their skin. Gustatory, this is they taste stuff and usually it's unpleasant. And then olfactory is they smell things and they usually um, it's bad smells when there's really not a smell there. Illusions, these are misperceptions or misinterpretations of real external stimuli. So they may see something, but they misinterpret it what it is. Echopraxia, they imitate movements made by others. You see this a lot in children. My little grandsons do that with us, but as an adult, you shouldn't do that. You shouldn't, they'll mimic how you move and hold your hands and stuff like that. So those are the positive symptoms. So the negative symptoms, we are going to talk about something called affect. And affect is basically a feeling or an emotional state, how somebody looks, how they're behaving. You can have different forms of affect. And as a mental health nurse, you would actually write in your nursing notes if they had a flat affect or a bland affect or inappropriate, or if they were apathetic. Inappropriate affect is inappropriate when the individual's emotional tone is incongruent with the circumstances. A young woman laughs when told that her mother died. That's inappropriate affect. Your response to something is the opposite of what it should be. Bland or flat, the person is void of emotional tone. They don't show no emotion. Their face literally looks flat. Their muscles don't move. Their facial expression doesn't move. They just have the same look on their faces, like bland or flat. Apathetic or apathy, they demonstrate an indifference to or disinterest in the environment. They show no interest in what's I need to take a bath, I need to eat. They're just apathetic. Avolition is the inability to initiate goal-directed activity. It may take the form of inadequate interest, lack of motivation, neglect of activities, such as personal hygiene, eating, taking care of themselves. They just don't have no interest in anything. They're just apathetic. They show lack of interest in personal skills. Um, they show lack of insight, um, and no anosognosia. And I'm not sure if that's correctly how you pronounce it. I always have trouble saying that word. This is the most common predictor of non-adherence to treatment. Um, with this particular area, lack of insight, the individual lacks awareness of even being there or even having a disorder or anything. Waxy flexibility. Before we go to that, let me talk about anergia and anhedonia. Anergia is a deficiency in energy, and anhedonia is the inability to experience pleasure. This is distressing because it may increase one's risk for suicide. It can be very depressing when they don't experience pleasure. So, waxy flexibility. This is a condition in which the client with schizophrenia allows body parts to be placed in bizarre positions. They almost look like a contortionist in a circus act. They can just really put their body in bizarre positions. And you can't unfold them either. They have to get out of it themselves. Posturing, again, this is inappropriate or bizarre positions. They pace and rock. Regression, they go to an earlier level of development and they may be, tend to act like a child or wet their clothes. And they may have abnormal eye movements. Their eyes may kind of jump a little bit, like a twitching. Nursing process. Review Table 15-1 for nursing diagnoses. You have impaired communication, delusional thinking, withdrawal, sad, dull affect, risk factors, loose associations, and so forth. And you also have the plan of care, which goes from page 355 to 360. 359. I like to get a lot of questions from the care plan. I can't cover all of this because this PowerPoint would be way too long. I'm already at 32 minutes and I'm probably losing your interest by now. Make sure you read over the nursing diagnoses, how they're written, and the nursing interventions. And there's numerous ones like the one I told you. Tell the voices to stop. Be very careful how you approach a schizophrenic patient. Do not touch them. They'll think it's threatening. Disturbed thought processes. There's 4 interventions there. Try not to change their routine. Use the same staff. If they're talking about suicide, this is on 357. Ask them, do they have a plan? You seem anxious. How can I help you? Stay calm. Don't rush them. Don't force anything on them. Please make sure that you read the care plan. For your outcomes, which is on 353, the overall outcome is you want the patient to be safe and you want them to be able to have some kind of functioning ability. You want them to be able to take care of themselves and not harm themselves. These are listed on page 353. The nursing process, again, these are listed for you on page 355, 56, 57, and 58. Table 15-2, that's the care plan. Again, make sure you read over the care plan, and I've covered a few things of this with you, but read over these nursing interventions, okay? An evaluation, this is on page 361. Did the patient meet the goals? Are they safe? Has their agitation subsided? Are they able to go to group therapy? Are they able to have a conversation with you? Are they eating? Are they taking a bath? Those kinds of things. And then we get into treatment modalities on page 364 and reality orientation. This is where you redirect them. Today is such and such. Today's date is you are, in this facility. Your name is. This is your birthday. These are your family members. Reality orientation. And let them know that they're safe. Let them know they can trust you, and by being there for them, talking with them, showing them respect, giving them time to do things. Group therapy, that here they can talk about, how schizophrenia affects their lives. Behavior therapy, this looks at finding ways to get rid of the thought disturbing processes. Like I said, tell them to stop. It helps them be creative in changing their behavior. Social skills training, getting them back out into society if at all possible, and this may never happen. It is a slow process. And then family therapy, most of the time, like I said, these people aren't able to function. Somebody's got to take care of them, and so we need to get the family involved as well. Common features, you see this on page 365. Long-term programs are 9 months to 2 years. Client and family are involved. You got to give them information, education. They need to stay on their medicines. A lot of times, the reason people experience the symptoms of these mental illnesses is because they're not taking their medications. They need to do that. On page 367, it talks about the RAISE approach, and the R is recovery, the A is after an initial schizophrenic episode. With RAISE, the RAISE approach is a coordinated specialty care for first episode psychosis. With coordinated specialty care, the young person experiencing first episode psychosis works with a team of specialists to create a personal treatment plan and that fits those patients' needs. Some of the pharmacology, Thorazine is one of the drugs of choice. You can also use antipsychotic medications. Neuroleptics, these are your antipsychotics. There is a list on page 15-3. And also on page 80 and 82, there's a medication there I want you to look at too, and there's a slide on this. Side effects of Thorazine, you see these listed here. Dry mouth is a side effect of a lot of these medications, and these extrapyramidal symptoms. This is like where they can't stop rolling something in their fingers. They can't stop moving. They may take their tongue and thrust it out constantly. It also affects their heart rate, their urinary retention, their weight. We need to monitor their heart rate. If they have a prolonged QT interval, this needs to be reported to the physician and hold the medicine until you get further instructions from the physician. And seizures can be a side effect, so we need to make sure we're monitoring for seizures as well. On page 80 to 82, it talks about clozapine, and this is an appropriate medication for schizophrenia as well. But one of the side effects is agranulocytosis, and this can occur within the first 3 months of treatment, and you will see a sore throat, fever, and malaise. You need a complete blood count. There's a significant risk of granulocytosis with this drug, or clozapine or clozaril. Hypersalivation is most common, and tardive dyskinesia. And this is part of those EPS symptoms, and you have bizarre facial and tongue movement. If you see these symptoms, you need to hold the medicine. This can be a major crisis, and the physician needs to be notified.